for me to be part of that international meeting of worldwide scales, which is like a scientific platform for sharing knowledge, experience, because as I've understood from the conception, it is a basic issue to comment on the most essential problems of children's health in different periods of childhood. Why I've decided to share with you some conceptions and practical experience concerning tooth decay, because from one point of view, tooth decay or different non-cavitated and cavitated carious lesions, it is accepted as an infectious disease because some of the etiological factors are associated with the pathological activity of the microorganisms Streptococcus mutans and Streptococcus sobrinus, basically. And from another point of view, the tooth decay is a kind of a behavioral patterns associated disease because the etiology and pathogenetic mechanisms of tooth decay are associated directly or indirectly with the behavior, with the habits, sometimes harmful habits of children and their parents. What do we mean? Let me just point out the etiological factors about tooth decay, taking into consideration the fact that caries is a very widely distributed disease of destruction of the hard teeth tissues, which has as a result just diminishing effect of their functionality and showing dysfunction. From the other hand, associated also with aesthetic problems, of course, and can be a problem of primary dentition, mixed dentition, and permanent dentition. So just to point out the basic etiological factors of tooth decay. These are animal, the qualitative and quantitative characteristics of animal. These are cariogenic microorganisms, and most important row have just these, which are acidogenous and acidophilic, as I've mentioned, and also the fermentable carbohydrates, the so-called sugars. Also, when we talk about the basic etiological factors, we have to mention the time of the activity of microorganisms and the cofactor for that tooth decay initiation and progression, that is saliva, which has its double activity because it contains ingredients, organic and non-organic ingredients, some of them which have protective action against tooth decay, and others are just taking the role of predisposing factors. What about the pathogenesis of caries? Just to share with you that through the time there have been different theories concerning the genetic mechanisms of tooth decay, starting from the Miller's theory of acids-based pathogenesis of caries, with the basic activity of acids produced by cariogenic microorganisms, Streptococcus mutans and Streptococcus sobrinus, which are metabolizing very actively, very intensively the sugars. We mean the saccharose, that is a complex of fructose and glucose. And so we know that children all over the world are now under these conditions of being in close relation in their close and remote environment, in close relation with these harmful habits of very frequent sugars intake. And through the time passing, different theories concerning pathogenesis of tooth decay and the contemporary conception about the pathogenesis says there is firstly a process of demineralization of the non-organic compounds of animal, followed by dentin, and afterwards we have processes of deproteinization, respectively destruction of the organic compounds of animal. Why important? Because if we know and if we respect the basic and core etiological factors of caries, and we take care about the pathogenetic mechanisms, we will be able to control the process of caries, to have a kind of practice of efficient and effective management of the caries process itself, starting with demineralization followed by deproteinization. Why? Why sharing with you that information? Because to manage a disease includes, from one point of view, to have prognostic activities, to have activities of proper, adequate, accurate diagnosis related methodologies, to have also proper treatment. And nowadays, one of the basic conceptions concerns minimally invasive methodology of treatment. That means to preserve as much as possible of the hard teeth tissues, to preserve the vitality of the tooth, if possible, of course, if the clinical findings, the clinical situation itself let us preserve the vitality of the tooth, of course, distinguishing primary and permanent teeth with all of their specifics and characteristics. And another very important aspect is to preserve the tooth as much as possible into the teeth alignment, and in that way to preserve the interjaw relations, to preserve the proper functionality of the masticatory apparatus. To think about tooth decay and its proper management is associated also to the topic of taking care about gingiva, taking care about the other structural components of the supporting apparatus of the tooth, taking care about the functionality of the temporomandibular joint, taking care about the functionality of masticatory muscles. In that way, thinking about one tooth or a number of teeth or all the teeth, thinking about the primary, mixed, or permanent dentition of a child, and taking care to provide prevention and minimally invasive methodologies of treatment. That is a kind of taking care about the oral health status as a whole. And I'm really feeling myself happy to have that opportunity to be among all of you who are personalities with your considerable experience in different spheres of preserving health of children. And all of us know that overall health is associated with oral dental health and vice versa. So we just collaborating, being in contribution with each other, doing our best to solve the problems of different health disorders, just in relation and following the principles of multidisciplinary or interdisciplinary approaches of treatment of children. We know that that is the best way to solve all of these health associated problems, and of course that will have as a consequence just increase of the quality of life of children. And I'm absolutely sure that that is the purpose of all of us, not only the participants of that wonderful scientific platform of that congress, of that webinar, but that is the conception, that is the ambition of all of the doctors, dental medicine doctors, all the professionals in different spheres associated to health. Just if you let me share with you, when we are doing our practical work from one point of view when we are dealing our practical classes with students, and from another point of view when we are dealing our practical activities in our dental offices. It is really very important for us to start our meeting with the patient, respectively his or her parents, taking into consideration the fact that that is a child, to start with the medical history, to start with taking the anamnestic data. And that is logical, of course, and you will say that is nothing unknown, that is nothing unfamiliar, that is useful. Why just to mention? Because from one point of view, sometimes being overwhelmed with all of these professional duties, we just forgot or sometimes even ignore the fact that the common health status can reflect, can exert an impact upon oral health and vice versa. And today, unfortunately, there are lots of children suffering from diabetes mellitus, lots of children suffering from blood disorders, lots of children with recurrent respiratory tract infections, children suffering from gastrointestinal tract disorders, affecting organs along the gastrointestinal tract, children who are with epilepsy, with other neurological disorders, also not to ignore the fact that there are lots of children who are just if not saying classified or categorized, because I'm not sure that is appropriate to say, but children with some neurodiversity specifics, the so-called autistic children, autistic spectrum disorder, all the problems associated with hyperactivity and attention deficiency. It is not a secret for anybody that nowadays in the for the last decade, we can say, we have that rapidly increasing rate of children of the autistic spectrum disorder coming to our dental offices. Of course, that is such a status which is individually associated with lots of behavioral specifics, and different children just react to absolutely different ways in the dental office, and that is the predisposition to have the individually related, personally associated therapeutic approach, of course. But from the other hand, that tendency of autistic spectrum disorder distribution and impacts upon children is associated with the so-called syndrome of the screen children. We know that that has been developing as a kind of tendency. Contemporary parents being so busy with lots of duties, lots of occupations all the time, with that persisting lack of time, they say, okay, I don't have time, and sometimes just replacing the active communication with their children by the screens, telephones, computers, and TV, and others, which are just depriving the children from the opportunity to have really adequate contacts with their parents. Afterwards, that has its impacts upon their communication in the kindergarten, in the nursery, at school, and of course at the dental office. And that is one of the aspects, and I can say one of the problematic aspects of the management of tooth decay, to provide a favorable environment, to provide conditions, a favorable medium for proper communication with the child. Now, it is not acceptable when a child, nevertheless, if that is a child without any common health disorders, or with some systematic problems, or with some behavioral patterns associated problems, it is not appropriate situation if the child coming at the dental office for the first time, and we just say, hello, please sit down on the chair, open your mouth, I would like to see your teeth. I would like to treat your teeth. We need some period of accommodation. We need some period of adaptation. The child has to be absolutely convinced that there is nothing to worry about. There is nothing to be scared about, because if there are such negative emotions, that will absolutely block, that will hinder the proper therapeutic process. So we need adaptation, and saying hello, come, just to have that step-by-step approach, to show the instruments, of course, starting with the mirror, and not with the probe, with the sharp edge, never. Starting with the small brush, with the electric brush that is on the dental unit. Sometimes also drawing together with the child, sometimes trying to make teeth and model them. Sometimes just talking at the beginning, besides the medical history intake from the parents, talking about the hobbies of the child, talking about his or her interests and friends at the nursery or at school, about the favorite subjects at school and others, and explaining step by step the so-called hierarchization of the instruments, of the different sets of instruments. And after following these steps, after showing these which are absolutely non-invasive, then starting with explanation, that is not to say the turbine or the handpiece, because children will associate that with something that is a machine, that is very dangerous, that will break my tooth and I will never let you touch me. Not just there can be a kind of illusion, and just replacing the name of a handpiece or a turbine with some pen, that is a pen, or that is a pencil, or that is a brush with which we are trying to draw different drawings, different pictures on your teeth, and to make them healthy. We can just say that is a cotton roll, but we can say that is a pillow for a tooth. We can say that is the reflector light of the dental unit, but we can also say not. That is the sun shining in your mouth, and your your teeth just gleaming, being healthy and white and happy. That is one of the problems, to have these first steps of adaptation. Of course, starting with the medical history, that questionnaire dealing with the parents about any common health disorders, to be aware of that fact, to be aware of the fact of allergic reactions, of allergic situations. That is one of the obligatory first questions. What about your child? If there have been any allergic reactions till the moment, because allergic reactions can be towards insects, towards some pollens, towards some medicines, foods, and etc. Why important? Because while dealing with the treatment methodology performance, we are also using and so it is really very important for us to have all of these. At the same time, there are situations which I've mentioned. Children absolutely are rejecting to cooperate at the dental office. Children who are with very highly developed reflexive vomiting, not possible to do dental procedures in ambulatory conditions. Such children, of course, have the opportunity provided for pharmacological methods of treatment and situations of sedation and common or general anesthesia procedures. What other aspects we do talk about? First of all, we have to be capable to provide proper diagnostic activities. how to diagnose properly if we have a situation of a tooth decay affecting a tooth surface or not. Immediately you can react loudly or not. It's not a problem even to mention about, not to discuss. If there is a hole in inverted commas, or if there is a black hole, no problems, that is a caries. Yes, absolutely true. If we have such situations of the so-called cavitated caries lesions, which can be with different deepness, affecting animal, and upper one half of dentin, animal, and also not upper but lower one half of dentin, and almost reaching to the underlying pulp tissue, we talk about deep caries lesions, deep cavitated caries lesions. At the same time, there are lesions which are cavitated, but the so-called caries latenta. That means that is a process which has already progressed in deepness, affecting not only animal but also the almost entire layer of dentin. But we have a situation of no hole in inverted commas. Why? Because some of the calcium, phosphate, and other ions which are demineralized, which are distracted there from the underlying animal and dentin, are just going in upwards direction and making a kind of a filling in inverted commas and no visualized hole. That's why we have to be very, very attentive about that situation. How to recognize? We pay attention on transparency, translucency, about the so-called frosted-like seeming animal. We pay attention also on the allocation of the caries lesion on different locations, on different sites. There are differences in the way of progression of the caries process along fissures, pits, grooves on the occlusal surfaces of distal teeth, and also absolutely different is the situation when the caries process has already affected proximal surface of the tooth, mesial or distal. What else? The so-called non-cavitated caries lesions. That means the so-called white flecks or white spots. There can be also brown flecks or brown spots. Macula cariosa alba, respectively macula cariosa fusca. These diagnoses. What does it mean? That means that in these situations we have the first stage of the pathological process of destruction already started, already initiated, but that is a process of demineralization, respective destruction of the non-organic compounds. At the same time, the organic compounds of animal are safety yet, and there is no cavitation. So these lesions look like white spots or white flecks. What to do in that situation? In that situation, we have the first task to stop the process of progression of the caries and also to provide favorable conditions for restorations of the tissues there. How? Logically, if we have a process of demineralization, as already I've mentioned, based on the contemporary conception of the pathology of tooth decay, that means we have to do our best to provide therapeutic activities following the activities of products of remineralization. So demineralization and the opposite activity of remineralization, remineralizing products, remineralization therapy. But how to provide? Can we rely on the remineralizing medicines only? Not, of course. From one point of view, we have to take care and never to ignore the fact that after taking the medical history of the patient, we have to do the caries assessment risk or the caries risk assessment, both possible as a prophylactic and prognostic approach. What does it mean? For each child, for each individual, for each time, we have to pay attention on all the clinical findings, environmental characteristics, behavioral traits, which help us separately and in their combination make proper evaluation of the level of risk for caries. If we have a child who is regularly brushing his or her teeth with absolutely strict control of sugars intake, once or twice per day only as a dessert, not incessantly, not all the time through the day, not before going to sleep at night. If we have a child with proper topical or so exogenous fluoride prophylaxis application, children with endogenous fluoride prophylaxis application, if we have children who are clinically healthy or with absolutely properly controlled common health disorder, these children are categorized as children with low carriers risk. Respectively, these children, from a clinical point of view, will have a lower distribution of the carriers lesions for definite periods of time. That means not more than one carriers lesion clinically manifested for a period of 1 year. At the same time, if some of the clinical, environmental, or behavioral patterns associated factors are in another direction, the negative direction, there will be the situations of moderate carriers risk or high carriers risk. And if we have a child being in high risk of carriers, and that child is, for example, with the vestibular surfaces of upper frontal teeth affected by so-called macula cariosa alba or these non-cavitated carious lesions, what to do about that? Just to prescribe a remineralizing therapy with a tooth mousse and nothing else? Not, of course. We'll have to do a complex prophylactic cares from one point of view at the dental office, with scaling procedures, with polishing, with appropriate hygiene products. From another point of view, at home, the child has to use, based on his or her age, to use dental flosses after the age of 3, interdental brushes after the age of 6, mouthwashes after the age of 6, because that is the time of already developed a reflection of swallowing. Appropriate fluoride containing toothpaste, it's really very important. That is one of the problematic issues of the control of tooth decay today, because in lots of situations parents react, but how to apply a fluoride containing toothpaste that can be a kind of poison for my child? Not at all. If we use fluoridated toothpaste with appropriate amount of fluorides based on the age of the child from one point of view and based on the caries risk level from the other, that will not be dangerous, just the opposite. Will have a kind of positive effects. What kind of positive effects? The toothpastes containing fluorides till the age of 6, they have the double effect of endogenous and exogenous fluoride prophylaxis efficiency, because some amount of the paste is swallowed, approximately 25% of the amount being in the mouth of the child. And we use 500 ppm fluorides in the toothpaste in that situation, with the amount of a pea size. Morning and evening, and that in this way we have a very small delicate amount of that toothpaste may be swallowed, not absolutely sure, and the other amount, that is the toothpaste being in direct contact with the hard teeth tissues, it provides a very strong, a considerable, significant dental plaque related suppression effect, and also control of the suppression of the microorganisms activity with the so-called bacteriostatic effects. And for children between the age of 6 and 10, we have a fluoride containing toothpaste with 1000 ppm fluorides. Sometimes if the child is in high risk of caries, in the category between the age of 7 and 12, we have also toothpaste with 1250 ppm fluorides, or even more. Why? Because we have to provide that adequate care. Another aspect, in order to have efficient remineralizing therapy, proper tooth brushing, proper usage of all of the necessary oral health related products, and something else very, very important, to have proper control of sugars intake. It's not possible a child to consume sugar-containing foods and drinks all the time and to expect to have effect of the remineralizing therapy. Something else, to have the regular dental visits. We know that all the time, all of us suffer from that lack of time, tight knot, as we say. But for children being in higher risk of caries, it is very important all of these regular meetings to be on each 3 months. That means 4 times for the year. For children in moderate risk of caries, on each 4 months, that means 3 times for the year. And for children being in low caries risk, on each 6 months, that regular dental visits, regular dental checkups, that means on each 6 months for the year. Why important endogenous, so-called endogenous fluoride prophylaxis? Endogenous fluoride prophylaxis is associated to the period of formation of the crown of the tooth, initial mineralization, formation of the crown of the tooth, and pre-eruptive mineralization. And after eruption of the tooth, endogenous fluoride prophylaxis that can be provided by fluoridated running water, fluoridated mineral waters, fluoridated tablets, drops, fluoridated yogurt. After the eruption of teeth, endogenous fluoride prophylaxis has no effect, but we do rely on the exogenous fluoride prophylaxis based on fluoridated toothpaste, fluoridated varnishes, fluoridated foams, fluoridated gels, fluoridated tooth gums, all of these providing that topical or local exogenous effect. And once again, that is our role, the role of dental medicine doctors and especially pediatric dentistry specialists, to talk with the parents, to communicate, to motivate, and to explain that that is not a problem, that is a strong necessity to use fluoridated toothpaste, because in that way will be solved lots of problems. There will be saved time, there will be saved finances, there will be saved also suffering from the child. That is the most important. Remineralizing therapy can be efficient if we have proper plaque control. Otherwise, if there is not proper plaque control, there will be no adequate contact between the remineralizing product and the hard teeth tissues. And after some period of time, after prescribing the remineralizing product and the child comes for regular checkup, there can be also just the adverse situations. These initial caries lesions, caries incipiens as named, or macula cariosa alba, not disappearing as we've expected, but just becoming wider, enlarging their contours and increasing their activity. So all of these aspects are really very, very important. Why to treat primary teeth? Why? Immediately we can say, no problems about that. There is no need to treat primary teeth because these will be exchanged by the permanent ones. No matter about that. I don't care about that. There will be the permanent after some period of time. That is absolutely excluded, absolutely unacceptable. And unfortunately, there are lots of situations in which we have to explain, to motivate and remotivate parents that not treating, not taking adequate cares for prophylaxis and treatment of primary tooth or teeth. That is a kind of a predisposition to very serious problems with the permanent teeth. Why? Because if we have a kind of an inflammatory process, a kind of infection, better to say, on a primary tooth affected, for example, a primary tooth affected by pulpitis or periodontitis, respectively, that is a kind of infection as a result of the inflammatory process affecting the pulp of the tooth, or not only the pulp but also the periodontium. As a result of that, if we don't take adequate therapeutic cares, that inflammatory process can penetrate in deepness, because in most of the situations we talk about primary teeth being in definite process of already initiated and advancing root resorption. So there is active opening of the root canal system and direct pathway for penetration of these pathological substrates in the surrounding space. And these pathological substrates can affect the underlying tooth germ of the permanent successor. And this permanent tooth can erupt with some problems, with some macroscopically visualized qualitative and quantitative disadvantages of animal. And such animal affected of the affected by the so-called dysplasia, structural disturbance dysplasia, that tooth is absolutely vulnerable to the carriers attacks of cardiogenic microorganisms, and vulnerable respectively to the tooth decay process and its rapid progression. And that is one of the reasons under conditions of non-treated primary teeth with situations of pulpitis or periodontitis, that can be the reason for the so-called Turner's dysplasia of the underlying permanent tooth. Permanent tooth which will be just cursed to be with structural defects and respectively to be considerably predisposed to caries progression. That is one of the reasons why we today have, not in Bulgaria only, not on the Balkan Peninsula, not only in Europe, but all over the world, unfortunately, we have lots of children losing their first permanent molars before the age of 18, before the age of 20. Why? Just because of complications of tooth decay process and not taking care on time, or children with problems of permanent teeth because of situations of Turner's dysplasia, because there have been no adequate therapeutic activities on the primary teeth. Another problematic issue, the problem of traumas in child's age, especially smaller children. They are more predisposed on traumatic injuries in the facial maxillary region, affecting also one or more teeth. And if we don't take care about that primary tooth being affected, that can be a predisposing factor for affliction of the underlying permanent tooth. Also, another very important aspect is the aspect of interrelations in our professional activities between pediatric dentistry specialists and orthodontic specialists. Why important to be in close collaboration, to be in close communication? Because we have to pay attention on the fact that parallel to the process of growth and development of the child, we have all of these process of growth and development also reflecting on the facial maxillary region. And we have to not to ignore that in situations of an open bite or cross bite, uni or bilateral, or situations of progenia, the so-called medialization of the lower jaw, all of these situations are very important to be organized for consultations with the orthodontic specialist as soon as possible. Otherwise, there can be some problems progressing in time, and afterwards the treatment will be really harder, more expensive, more time wasting, time consuming, and all of these, because it's not a secret for anybody that healthcare has different aspects, humanity aspect, personality associated aspect, but not to skip also the financial aspect. Not to ignore, we cannot ignore, because the quality of healthcare is associated with money, with expenses, logically. Another very important aspect, if you let me share with you, the problems of treatment of primary teeth when it concerns situations of pulpitis. There are different pulpitis, respectively inflammation of the pulp tissue, that is loose connective tissue allocated under the enamel and dentin layer, and very well supplied with blood vessels, with nerves, with abundance of cells, and is with very strong protective activity, regenerative activity, trophic activity, sensory activity. So our efforts are to preserve the vitality of the tooth principally. Nevertheless, that if that is primary or permanent, but if that is a situation of irreversible pulpitis, we cannot provide that. Or if we have a situation of periodontitis, we talk about devitalized pulp. But what about the vital methods of treatment of pulpitis in primary teeth? Of course, we can apply if we have a situation of reversible asymptomatic pulpitis and taking care about the dynamics of teeth, development of teeth. That means to pay attention on the fact what is the age of the tooth, when the tooth erupted in the oral cavity, at what age is now the child, and if we have a situation of root resorption not advanced yet, and having a situation of reversible pulpitis, no problems with no night pain, no spontaneous pain, no provoked pain or very short lasting provoked pain for only 20 seconds after elimination of the provoker, no problems. We'll use vital methods of treatment. Otherwise, we have to use non-vital methods of treatment. And sometimes there is the need of thinking also about anesthesia, especially if we talk about treatment of pulpitis, because the pulp is inflamed but vital. That means there will be sensitivity, there will be pain, and we are the people who have to care about pain suppression and no discomfort for the child. So here comes the moment for anesthesia, local infiltrative anesthesia and local anesthetic substrates, which have to be appropriate for the child. Very important to pay attention how much of the anesthetic to apply. It depends strictly from one point of view of allergic reactions, yes or not, from another point of view, common health status of the child, and from the other aspect, problematic aspect, to pay attention what is the body weight of the child, and in that way to calculate how much to provide of the anesthetic, not to do too much of that. It's really very, very important not to do too much of the anesthetic. That is very important because we can say, no problems, I will not think about vital methods, I will just devitalize the tooth and I will solve my problems. But if we have favorable conditions for preserving the vitality of the primary tooth as much as possible, that will be a kind of favorable condition for the underlying developing permanent successor. And treatment of periodontitis, no other option in primary teeth than non-vital methods because of the already lost vitality of the pulp tissue. Lots of comments, discussions about formalin resorption methodology to use or not. Today there are lots of alternatives, calcium hydroxide medicines, also zinc oxide eugenol in children who are not allergic to these, with very, very good long-lasting therapeutic effects. What about the permanent teeth? Again, we talk about minimally invasive methodology of the treatment of caries. We talk also about vital methods of treatment with indirect, direct pulp capping, vital pulpotomy, apex genesis. When it concerns situation of pulpitis that is irreversible pulpitis on a permanent tooth with non-complete root canal system development, here comes the moment of discussion of methodology of apex genesis or partial pulpectomy, the so-called. So our aim, our purpose is to preserve the vitality of the tooth, if not possible for the primary, to treat based on a non-vital methodology, and for permanent teeth all the time our purpose is to preserve the vitality of the tooth, following the principles of minimally invasive therapeutic steps. And if we have a situation of periodontitis on a permanent tooth with non-complete root canal system development, then comes the moment for apex fixation, the moment for apex fixation. Now I sincerely hope that I haven't burdened you with so much information, only speaking and speaking without any pictures, without any images. But initially I've decided to do that way because it's really important for all of us to be in close collaboration when it concerns the different aspects of health of children, with all of their physiological, neurological, behavioral patterns associated specifics. Never forgetting that each child is a personality. Nevertheless, if that is a baby at the age of 1 year and a half, because that it can also be a patient for us, such a baby just creeping afterwards, trying to walk, the so-called toddlers and walking babies, they are more predisposed to traumatic injuries, and we can have such patients in our office. Early childhood carriers, children from the age of 1 to the age of 3, very serious problem nowadays, a medical social problem with a very considerable socio-economic impacts. Children of the early school age, from the age of 7 to 12, with all of their problem specifics of the carrier's process, because they're in the so-called in the so-called period of late mixed dentition, and children after the age of 12, 13, when we talk about stable permanent dentition, and we pay attention, besides the problems of tooth decay and its proper control, also about the gingiva, taking care to minimize the situations of plaque-induced and plaque-associated gingivitis, especially plaque-associated gingivitis situations in which the dental plaque is an etiological factor, basic etiological factor, but not the only. In these cases, we do need strong collaboration with specialists in other spheres of medicine, in other spheres of science. So once again, thank you very much, dear organizers, for the provided opportunity to be a part of the webinar on pediatrics and midwifery. I sincerely hope that time sharing with the problematic issues of caries process and management of caries process in children has not been a waste of time for you, and I would like also to express my gratitude to the organizers for their understanding, for their collaboration, for their contribution all the time. That, in my opinion, is an absolute sign of high professionalism and humanity. Thanks a lot. God bless all of you. Health, prosperity, lots of scientific successes, and sincerely hope that I will have that fruitful opportunity to be together with you also in the future. Thanks a lot. If you have some questions, I'm on your disposal.